For our next disorder, we're going to be talking about inflammatory bowel disease, which is kind of like it's a general term that covers a couple different specific disorders that we're going to go into and describe a little more in depth. So the pathophys behind IBS or inflammatory bowel disease is really a chronic inflammation of the GI tract. Chronic meaning it's a long-term problem. Patients aren't coming in with acute diarrhea or acute symptoms. These are things that they've been dealing with for quite some time over a period of years, months, long-term chronic problems. The two big ones that we're going to focus in on for our inflammatory bowel disease processes are Crohn's disease and ulcerative colitis, which are similar, but there's some very distinct differences that we can tell them apart from each other. So Crohn's disease is a full thickness inflammation of the bowel, the full length of the GI tract. It can not infect, but it can be present anywhere from the duodenum all the way to the rectum. Ulcerative colitis is an inflammatory disease of the colon. So that's where the col comes from here. It's the colon. It's also only the mucosal layer or lining of the colon. So it's that inner lining where stool is coming in contact with the lumen of the bowel. And think of it as like the skin surface inside the colon or inside the lumen of the bowel. So this will only occur in the colon and the rectum. So it's a large intestine problem, whereas Crohn's disease is a small intestine and a large intestine problem. The etiology of both of these diseases, it is an autoimmune process, meaning that there's not a specific like infection that's going on or trauma that's going on that causes these things. They're both autoimmune in nature. The way that Crohn's disease tends to work is we have that full thickness inflammation of the bowel. So you can see all the layers of the bowel are inflamed, and it can occur in segments, meaning there's going to be areas of healthy bowel next to or adjacent to areas where there are not lesions of Crohn's disease. So we'll have areas of inflammation and areas of normalcy. Ulcerative colitis isn't going to be kind of a patchwork presentation like that in the body. It's going to be this whole region of the colon is inflamed and therefore has the ulcerative colitis. Because this also only affects the mucosal layer, so that inner layer, that's where we see the alterations in tissue presentation. We don't see it all the way through the full thickness of the bowel. So those are the big differences between Crohn's disease and ulcerative colitis. The presentation and the symptoms is also very different as well. Some of what we're looking at, if we look at them, right next to each other and directly compare these, abdominal pain is present in both disease processes. Diarrhea is present in both disease processes. However, the appearance of that diarrhea is very, very different. With Crohn's disease, patients are going to be having diarrhea because it's going to infect the entire gastrointestinal tract, but they're just going to have normal stooling diarrhea. Ulcerative colitis, they're going to have abdominal pain, diarrhea. The difference is there is always bleeding associated with ulcerative colitis, and there is not bleeding associated with Crohn's disease. So that's one of those big differentiators that we can use based on a patient presentation or the stool that they're eliminating, that we can tell the difference, whether this is a Crohn's disease problem or an ulcerative colitis disease problem. So for assessment, again, we're looking for what is the presentation and how can we differentiate which problem is which, what's going on with that patient. If they're having Crohn's disease, they're going to have colicky abdominal pain, meaning it's going to go through periods of exacerbation and remission as far as their presentation of pain. There's going to be times where their pain is almost intractable, meaning very, very severe, and there's going to be other times where they don't experience any abdominal pain. And part of the reason for that is it depends if there's stool content moving through those patches or segments of diseased bowel. If it's moving through areas of normal bowel, they're not going to have symptoms. If stool content is going through a section of diseased bowel, they're going to have symptoms. Diarrhea, definitely a thing. Massive fluid and electrolyte loss, right? Absorption is a big problem for any patient that has diarrhea. So these patients typically have weight loss and malabsorption syndromes. So despite the volume that they're consuming, they may not actually be absorbing anything, and they may have malnutrition associated with that. For symptoms of ulcerative colitis, we have some similar presentations. So again, abdominal pain and diarrhea are going to be very, very present in these patients. They're also going to have the fluid and electrolyte loss from that frequent stooling, but they're also going to have that bleeding element as well. So hemodynamic stability is a much bigger deal with our ulcerative colitis patients than it is with our Crohn's patients. Pain and fluid is a big deal here. Pain, fluid, and hemodynamics are a big deal with ulcerative colitis. But again, weight loss, malabsorption, that's going to apply to both because of the frequency of stool that these patients are going to produce. And when we talk frequency of stool, this is what we're talking about, right? So a mild presentation of either disease is 1 to 2 stools per day, right? Moderate presentation is 4 to 5 stools per day. These are usually patients that are not going to be seeking health care for their exacerbation of disease. This they can usually manage at home. They may be talking with their gastroenterologist or internal medicine physician as an outpatient to manage their presentation at this phase. When it gets severe, when they're having 10 to 20 bowel movements per day, that's usually when they're going to seek care. That's when they're going to be hospitalized, and we're really going to have to look out for either that hypovolemia from blood loss, volume loss, or just volume loss, depending on the etiology of their inflammatory bowel disease. For the medical diagnosis component of inflammatory bowel disease, we're going to start off, as always, with our least invasive means, moving towards our more invasive. So first line of kind of evaluation for a patient with this problem, because it's a chronic problem, honestly, asking them what's going on with them, they'll tell you like, oh, I'm having a Crohn's disease exacerbation, or oh, I'm having ulcerative colitis, I've had it before. It's not as common to deal with adult patients who this is their first presentation of this disease. Usually people are diagnosed with these disorders kind of in their teenage years or preteen years, and they're going to be living with them long term. But some of the objective measures, some of the data we're going to collect to show that this is an active disease process, our CBC will show things like anemia. Patients will become anemic because of the inflammation associated with the disease and the autoimmune component as well. White blood cells are going to be elevated, especially if they have some of the complications of these diseases, such as perforation, meaning there's a rupture or a tear in the bowel, or this life-threatening complication, which is called toxic megacolon. And that's exactly what it sounds like. Toxic megacolon is it's a massive volume of stool that's retained in the colon, causes massive dilation of the stool, or not of the stool, of the colon, which can cause like a shock presentation in our patients, which can be life-threatening if that stool content isn't removed. So that could be a big, big problem for our patients. Electrolyte loss, especially due to the frequent diarrhea, if they're in that severe category where they're having 10 to 20 diarrhea bowel movements per day, they're definitely going to be having electrolyte and volume loss. Another one we look at is our ESR, which is, I think it's like erythrocyte sed rate. But what this ESR lab is for, so this is a blood draw lab, it's a marker of inflammation. It'll let us know if there's an inflammatory process going on in the bowel or anywhere in the body, right? If their symptoms are all GI related and we have a positive ESR, that's going to let us know that they have inflammation in their bowel, right? We're not going to go looking for some other place in the body other than where they're having symptoms. So here you can see this is the same patient, both when they're not having an ulcerative colitis exacerbation, and here's when they are. And we can see that beefy red inflammation that's invading into the mucosal lining of that person's colon, which is really kind of sad to see. And then again, for Crohn's disease, here's a healthy colon, here's a Crohn's colon. So we can see that kind of striation of damaged tissue intruding into the bowel. So this is an area where they're having a lesion of their Crohn's disease exacerbating. If we can't manage the disease or identify the disease non-invasively, we're going to move to invasive. And by invasive, we're going to try and do direct visualization. We want to see the inflammation or see the lesion where this is happening. So we're going to be doing our endoscopy procedures, but we're going to be doing them rectally, not orally. So a sigmoidoscopy, we're going to look at just the sigmoid colon, right? So just the distal end of the GI system. For a colonoscopy, we're going to look at the entire colon, right? And we want to look for where is the physiologic abnormality where the disease is present. The other thing that can be done when endoscopy is being performed on the bowel and the colon is a biopsy can be collected if it's indicated. Meaning if they see abnormal tissue, they'll collect a biopsy or a tissue sample of that abnormality to look at it under a microscope to identify, yes, it is in fact that disease process at work. The other one is capsule endoscopy. This is present for, we use this for Crohn's disease, right? Because Crohn's disease can affect both small and large intestine, whereas ulcerative colitis is only going to be a colon type of illness. So we can do our colonoscopies to visualize ulcerative colitis. For Crohn's disease, because we have small bowel involvement, we may need to do capsule endoscopy to visualize the lesions in the small bowel that we just can't reach with our colonoscopy equipment. So nursing diagnoses that we're going to be dealing with for inflammatory bowel disease, anxiety is one. So there's a big psychosocial component associated with the chronic nature of these inflammatory bowel diseases and the frequency of stooling that patients are going to experience as a result of having these diseases. Fear is another big one. Social isolation, absolutely. Also pain. These are all like cramping disorders of the abdomen. So even though these are chronic diseases, acute pain can absolutely exacerbate when they're having a flare of one of these diseases. That tends to be the terminology that patients use around ulcerative colitis or Crohn's disease, is they're having a flare-up of their disease. So that's kind of one of those ways that we can describe an exacerbation of symptoms in our patient. So the medical plan, when we're treating these medically, meaning not with a knife, we're going to be doing anti-inflammatories. There are some anti-inflammatories that are GI specific, so they're going to affect the lumen of the bowel specifically and not holistically. And then we're also going to be looking at doing some general anti-inflammatories, such as IV steroids. Solumedrol, IV solumedrol is one that I see that's given quite a bit for Crohn's disease patients and ulcerative colitis. Antimicrobials, especially for ulcerative colitis, because we have that acute inflammation. There's a high risk of an infectious process or a secondary infection developing because of that kind of hot area of inflammation. And immunosuppressants, because the etiology of a flare of one of these diseases is autoimmune, we are going to be giving immune suppressants after that steroid therapy has been started in order to suppress the exacerbation of disease. One of the big things to note here after steroid therapy, steroids themselves can be immunosuppressants, so we do not want to we're going to give steroids for the acute onset of their flare of disease, but once we've managed the acute onset, then we're going to transition off of steroids onto immunosuppressants because we don't want to double down on the immunosuppressant kind of properties of both of those medications. And then surgically, for patients who have had multiple exacerbations of disease, especially Crohn's disease, they're going to have many partial bowel resections. So you'll see lots of abdominal scarring from past surgeries. They'll be able to describe different surgeries and how much bowel has been removed at different times in their lives. But they will have many, many, many partial colectomies or partial bowel resections, both small and large intestine. If their disease becomes very advanced or it's later in life for these patients and they've already had segments of bowel removed, they could get a total colectomy, meaning the entire colon and rectum could be removed. Meaning that's all that's left for them is their small intestine. What can happen here and what the surgeon tends to create is what's called an ileoanal reservoir, which is where the stool is collected. So they'll take the ileum and kind of reserve a part of the distal colon where one of the sphincters remains so they can still maintain stool continence. A total protocolectomy can also be done, and this is like a permanent ileostomy type presentation. So the entire colon and rectum are going to be removed, and we're going to create an ostomy, which is just a surgical opening or an opening to the body. So they're going to pull part of the small bowel through the abdominal wall, and that patient is going to be stooling into a collection bag, sometimes permanently, for very severe presentations of both ulcerative colitis and Crohn's disease. And we'll talk more about colostomies and ostomies in general in the lab section. I can't remember if it's lab 1 or 2, but it's in one of those presentations. I think it's lab 2. But those are the surgical managements. We're going to be removing part or all of the bowel contents or bowel segments. For our nursing plan, we're looking at symptomatic relief, right? We're going to be managing the symptoms of these patients. We can't really control or do a lot of nursing interventions for autoimmune diseases, but we can do a lot of things for the symptoms that they experience as a result of those autoimmune diseases. So things like inflammation control, heat packs, cool packs, anti-inflammatory medications, pain management also, especially externally from the frequent stooling. These patients are going to have rectal skin breakdown from stooling 20 times per day. It's also, when you're stooling that much, it's high acidity stool. So they can have skin injuries around their rectum. And also stress management. Right? It's extremely stressful and humiliating for these patients to go through these exacerbations of disease. So we do need to be sensitive to that and help them through these disease presentations. And then medication management. They're going to be on immune suppressants and immune system management. They will have done that as an outpatient. We need to make sure that we're collecting all that data from those patients as to what their kind of home regimen of medications is, and try and get back to that baseline management as quickly as possible. So managing their immune system, also a big, big deal. For surgical management, because a lot of times patients will move towards a surgical solution permanently, if not at least temporarily, we may need to focus in on post-op teaching or preoperative teaching, especially around ostomies. Most patients who have Crohn's disease will go through some period of their life where they're going to have an ostomy. It's just variable whether it's temporary or permanent. But we do need to prepare them for having that stoma or part of their bowel pulled to the outside, and they'll be stooling into a collection bag, not stooling through their rectum into a toilet like they have, like the natural method. So ostomy assessments after teaching, also a big deal because we're pulling an internal organ outside of the body. We need to make sure that that is happening appropriately and there's no signs of complication associated with that surgical procedure. So for the implementation, the things we need to be doing for these patients: medical management, symptomatic support, and nutritional consultation. The higher the volume of stools, the more nutritional support these patients are going to require, because it's a malabsorption syndrome, right? They're not able to absorb any of the nutrient content that's flowing through their body. Surgical management, ostomy is a big deal, right? There's the routine stuff that we need to look at for any kind of like colectomies or partial bowel removals, which is like a surgical incision. We need to make sure it doesn't get infected, all the routine stuff. But ostomy assessments for this particular problem is a big, big thing, right? We need to make sure that we're monitoring these if it's a new ostomy after surgery at least every 4 hours to make sure that that internal organ that's been pulled through the skin is healthy and isn't showing signs and symptoms of complications. Signs and symptoms of complications include necrosis. So things like tissue death to that stoma. What they should look like is healthy, pink, almost like little mushroom caps that are just outside the skin. Things that are bad is if it's bluish, that could indicate a lack of circulation to that area. It's a cyanotic tissue. So we want to look out for tissue necrosis, meaning black tissue, or kind of cyanosis, poor perfusion, which would be like a bluish type of color. Any discoloration that's not a healthy pinkish red is really indicative of some kind of circulatory problem around that stoma and where it's been pulled through the skin. Because the two ways that it can become necrotic or inflamed are either the tissue itself of the bowel that's pulled through the skin loses circulation, or the incision on the abdomen that's been made, if it swells too much, it can constrict and strangulate the part of bowel that's been pulled through. So we do need to be very careful at that. And then our incisional assessments, just the regular abdominal incisions for these surgeries, we need to monitor those very closely for infection, especially in those first 48 hours after surgery, because that's when they're most vulnerable to infection, is those first 2 days. Then for evaluation, the things we want to see happen, our goals for these patients. For medical management, we want return of normal bowel activity. If they were stooling 20 times a day, we need to get back into that 1 to 2 times per day, or whatever normal frequency that patient had before this exacerbation of disease. Also resume normal ADLs, whatever their level of functioning and independence was prior to this flare-up. We want to get back to that level of independence after or with medical management. And then symptom relief. We don't want to have any more of the diarrhea. We don't want to have any more of the pain. We want them to be well managed and able to cope with resuming their regular activities of daily living. And body weight. Body weight is a big, big thing. We want them to have a stable body weight, meaning it's not rapidly changing. An unstable body weight would be periods of extreme kind of weight gain and weight loss. So we want to see them be able to maintain an appropriate weight over a period of time. We'll probably start this in the hospital, but as an outpatient, we're really going to monitor these patients long term to make sure that they're not having those dramatic or unstable weight changes. This is particularly important for ulcerative colitis because of the volume of stooling that those patients can have. And then surgical management, if they did have a surgical procedure, first and foremost, the incision care, we want to make sure that they can take care of their incision and that they leave any hospitalization with no signs and symptoms of infection. If they go with an ostomy, we want to start that ostomy teaching before they have surgery, and we want them to demonstrate that they can take care of that ostomy independently prior to leaving the hospital, because they may be living with that ostomy long term, so we need to make sure that they can take care of it long term. That includes changing the dressing around the ostomy and managing the collection bag where stool is going to collect continuously. Because we've bypassed the bowel above the level of the internal and external sphincters that make a patient continent, they're going to be incontinent of stool through their ostomy. So they're going to need to manage that device independently at home. So we do need to make sure that they're able to do that, and we start the teaching for that very, very early on in their surgical recovery. That's it for our inflammatory bowel diseases. Next, we're going to get into diverticulitis and diverticulosis.